Good morning, everybody. Thank you for coming to the third annual Synapse Roundtable. My name is Michael Graglia. I am the Managing Director of the Syngap Research Fund, and it is such a thrill to welcome our incredible speaker here today. Our next speaker is Dr. Constance Smith-Hicks from Johns Hopkins, the Kennedy Krieger Institute. I can't say enough nice things about her, but in the interest of time, I will just let her wow you herself. Dr. Smith-Hicks, take it away, and thank you for being here. And I will brag that she is on our SAB. We have the privilege of her. Over to you, Connie.
Okay. Hi, everyone. Can you see my slides?
Yep.
Okay, wonderful. All right. So thanks, Mike, and the organizers for inviting me. So I'm going to talk about sleep and synaptopathies. I'm going to briefly just talk about an overview of synaptopathies and then why we chose to study sleep, with some focus on some of our work looking at sleep in Phelan-McDermott and Syngap1. Then I'll end with a little summary and some next steps and perhaps some thoughts about limitations of the work that we've done so far. So, when we think of synaptopathies, we're thinking about disorders of the nervous system in general, but it can certainly be a consequence of dysfunction at the synapse, both peripherally or centrally. But for the purposes of this talk, I'm really going to be thinking about what occurs centrally, meaning in the central nervous system. So there's been a significant increase in the number of genes that have been linked to NDD, and currently there are thought to be over 2,000 genes that have been associated with neurodevelopmental disabilities. Many of them function at the level of the synapse, both presynaptic and postsynaptic. But the schematic here features 3 genes that are being discussed today. So STXBP1, SHANK, and Syngap1. And what you'll notice is that STXBP1 primarily functions in the presynaptic compartment, whereas SHANK and Syngap primarily function in the postsynaptic compartment. And SHANK and Syngap are involved in synaptic plasticity mechanisms, whereas STXBP1 is primarily involved in release of neurotransmitters. So we know a lot about the clinical features of all 3 disorders just in general. We know that they are certainly associated with a complex clinical phenotype that will include global developmental delay, intellectual disability, autism, and epilepsy. And we know that sleep is a common feature in many neurodevelopmental disabilities. In individuals with Syngap1, it's reported to occur in about 62% of individuals, and then in individuals with Phelan-McDermott, in anywhere between 25 and 50% of individuals. And I think from the previous speaker slide, I think we had probably 62%, if I recall, or 56% if I recall. Now, although sleep difficulties are reported in patients with intractable epilepsy, and we see significant epilepsy in individuals with STXBP1, the prevalence of sleep disturbance in that population is not entirely clear. So the focus of our conversation is really going to be related to SHANK and Syngap1. So why study sleep? Well, it certainly is an area of unmet need, and we know that sleep is critical, and good quality sleep is critical for many physiologic functions. It supports neurogenesis, plasticity, brain development, and behavioral function. And any parent of a child will tell you that poor sleep negatively impacts behavior, and there's this bidirectional association between sleep and mood, and certainly sleep and cognition. Thus, poor sleep not only impacts the child, but also impacts the caregiver. Sleep is not just a common problem in neurodevelopmental disabilities, but it is pretty prevalent in the general pediatric population, and approximately 25%, so 1 in 4 children who are otherwise typically developed have sleep problems. And depending on the nature of the neurodevelopmental disabilities, the prevalence of sleep can be anywhere between 50 and 95%. Sleep difficulties may manifest either with difficulty with sleep onset, sleep maintenance, problems with having increased daytime sleepiness, or breathing challenges occurring during sleep. So work from several groups in preclinical models of SHANK shows that the SHANK protein is involved in circadian rhythm of, and these studies are actually done in rodents, but the synaptic level of SHANK protein varies over the course of the day. And the changes correlate with changes in serum melatonin. Now, mice lacking exon 21 in SHANK3 are shown to have less sleep during the dark period. And this disruption in SHANK3 expression is also correlated with disruption in expression of many of the genes that regulate the circadian rhythm. So based on this, we know that SHANK3 is important for the regulation of sleep. And just a note I want to make, the exon 21 in SHANK3 is actually one of the hotspots for many of the pathogenic variants that are seen in individuals with PMD. Like SHANK3, SYNGAP1 is also an important regulator of sleep. And SYNGAP1 is expressed in the suprachiasmatic nucleus, which is the brain circadian clock. Its levels vary over the course of a day. And in rodent models that are haploinsufficient for SYNGAP1 have increased activity during the dark phase relative to wild-type mice. So why did we compare sleep in SYNGAP1 and Phelan-McDermott? Well, we opted to look at these two disorders because, one, they have shared clinical features, and their genes converge on shared molecular pathways and have shared physiologic consequences. We studied sleep in this population, and the patients were recruited from 3 sites, 2 in the US and 1 in the UK. We recruited patients with SYNGAP1, Phelan-McDermott, and typical developed siblings. We took all comers from as young as 3 years old on up. What we noted was that there was no significant difference in the number of males versus females for either of the 3 groups that were included in this study. I shared earlier that sleep is a common problem in both SYNGAP1 and Phelan-McDermott, and so it's not surprising that many of the patients were taking at least one medication that is routinely used to treat sleep. You can see that melatonin is by far the most common medication that's used in both groups of patients. We used the children's sleep habit questionnaire to evaluate the sleep profile. This is a parent-reported screening measure, and it evaluates behavior or sleep difficulties that are both behaviorally mediated as well as medically mediated. The CSHQ has been validated in kids between age 4 and 10, but it's been used in children younger and children older. And a total score that is greater than or equal to 41 suggests clinical significance of disrupted sleep. Not only do we look at the total score, but we are also able to parse sleep features along 8 subscales, looking at certainly resistance to going to sleep, delayed sleep onset, how long the child remains asleep, anxiety, parasomnias, and breathing-related difficulties, as well as daytime sleepiness. So using the CSHQ, we first asked, is there a difference in the total score? And then the subscale scores between all 3 groups. And we show that individuals with Syngap1 and individuals with Phelan-McDermott both had more severe sleep problems when compared to their typical developed siblings. However, individuals with Syngap1 had more sleep difficulties than those with Phelan-McDermott, and that's indicated by the higher total mean score. This difference between Phelan-McDermott and Syngap1 seems to be driven primarily by differences both in bedtime resistance and a difference in daytime sleepiness, where you see that Syngap1 individuals had higher scores on both. We also noted that nighttime awakenings, parasomnias, sleep disordered breathing, and sleep duration were common problems in both Syngap1 and Phelan-McDermott individuals. Because there is, in general, thought to be an age difference in the manifestation of sleep difficulties, we divided our cohorts in those who were younger than age 11 and those who were older than age 11. And another motivation for doing that is, again, because the CSHQ was validated in those younger than age 11. So we asked, is sleep difficulties in these disorders age dependent? And so we looked at this pattern, and we can see again that individuals with Syngap1 had a higher total sleep score, so a worse sleep profile than individuals with Phelan-McDermott. And we saw that pattern in those who were younger than 11 years of age, so those who were prepubescent, and that's consistent with what we saw when we looked at the larger group. We also see that the difference is the difference between these 2 groups is driven in this case by sleep anxiety and also by daytime sleepiness, and a difference in parasomnias between individuals with Syngap1 and siblings as compared to Phelan-McDermott and siblings were, there was no difference between those with Syngap1 and those with PMD, and both disorders had more increased severity of parasomnias as compared to typical developed siblings. We then ask, well, what is the profile of sleep differences that we see in the older groups? We can appreciate immediately that there was severity of sleep challenges in both Syngap1 and Phelan-McDermott when compared to typical developed siblings in many of the sleep subscales, that there was no significant differences between older individuals with SYNGAP1 and PMD. So in summary, we see that sleep is a common problem in NDDs in general. Both the SHANK3 and the SYNGAP1 protein are important regulators of sleep. We see from our data that there is greater sleep difficulties in individuals with SYNGAP1 when we compare them to those with phelan-McDermid, and we believe that this is dependent on age. So the younger SYNGAP kids have more sleep difficulties compared to younger individuals with SHANK3, whereas the older individuals with PMD seem to have more sleep difficulties than their the younger individuals. Parasomnias, nighttime awakening, and disordered breathing are common features. I think, this data suggests that both the total and subscale scores in the CSHQ can be useful measure for evaluating sleep. I think that it'll be important for us to look at the utility of this in natural history study and what it tells us about the sleep profile over time for populations with SYNGAP1 or other synaptopathies. One of the questions we often wonder about is, how does the CHSQ or any other measure that we use, how does that change over time when we think about treatments? And that's something that we are looking into. I mean, we generally put many of our patients on medications that treat sleep. And so this would be an easy thing to do, at least in the clinics. So I want to stop here and acknowledge certainly the families and children of SYNGAP1 and SHANK3, the parent advocacy foundations. The work was done in collaboration with Jimmy's group in Texas and Andy's group in the University of Edinburgh, and certainly all our funding organizations. So I think I have probably 2 minutes for questions. Okay. And I see a question here in the Q&A that says, do you see a wearable tracker as being a way to follow sleep habits over time? Absolutely. That's actually one thing that we are embarking on, and we're in the process of analyzing that data. I think wearable tracker, we may be able to correlate activity and delayed sleep onset or latency to falling asleep with the CSHQ. Some of the other measures, I think that might be challenging, but yeah, that is something that we and others are doing, and we just don't have the data yet to share. Okay. And do you think that sleep could improve with treatments? So absolutely. Genetic treatment. So do you think that sleep could improve with genetic treatments? Absolutely. I think, if we are, there are many approaches that are being proposed for genetic treatments, whether it's antisense oligonucleotides or other modalities, whether it's read-through or many other approaches. And if we are able to get target parts of the brain that certainly are involved in regulating sleep, then it would be my expectation that sleep, we should be able to improve sleep. And sleep generally, in my opinion at least, is a low-hanging fruit. It's one of the things that we are able to treat to some degree in many of our patients. I wonder, in the data that we showed, you might have noticed that the sleep onset delay was, there was a lower subscale score, although significant when compared to typical developed peers. But I wonder if that lower subscale score and consequently less impairment in delayed sleep onset is related to the fact that many of these kids are on medications that their role is to increase sleep, so target delayed sleep onset. And so I wonder if we are being effective in shortening the latency to falling asleep in many of the patients with the current medications we use. My expectation is that targeting sleep will improve behaviors. Will it be a cure? I don't think so, but it'll be one of the treatment interventions that we would likely employ as we think about how we treat patients with SYNGAP1, SHANK3, STVX, STXBP1, and other similar disorders.
Thank you so much, Dr. Smith-Hicks. Sleep, I'm glad to hear you say low-hanging fruit. I hope that will be the case. It's obviously something that can really impact quality of life.